Assalamu alaikum wa rahmatullah. I would like to thank the organizing committee and congratulate them for this very nice, high quality, excellent topics, very useful. I come from the era of old generation rheumatologists. During my time, we had only sulfa, hydroxychloroquine, methotrexate, وآخرنا كان الجولد. يعني we used to use gold and we used to have gold clinic. And we used to see a lot of nodules and deformities and new MIs in young patients. And yes, new medication have side effects, I agree, but everything in life have side effects. The car have side effects, the airplane has side effects, even marriage has side effects. فين المستني أنا ترى من أول أضيع كلام. Where is my presentation, or should I go here? Okay, I have nothing to disclose. So my presentation is only a few questions. It's a very short presentation. It will not be long. And I have questions, and I have most of the answers. So the first question, what is rheumatoid arthritis? We all know that rheumatoid arthritis is a chronic, it's long-lasting, it's lifelong disease, it's an autoimmune disease. And we can compare it to diabetes or to autoimmune thyroiditis. In these diseases, do we stop? Do we taper our medications? The answer is no. Why do we treat rheumatoid arthritis? I will leave this unanswered because I do remember when I was in my training, Dr. Keystone, when he came to our center, he was talking about biologics. We were all very excited that we will have a new medication that will save the patients from the pain and the agony, and it will save their jobs. Their job loss will not be there anymore. Most of our patients are young patients. Question 3, in rheumatoid arthritis, what's our aim? Is our aim to cure or to control? All autoimmune disease, the aim is to control. And our gold standard example is thyroid or diabetes. Actually, rheumatoid is more difficult than that. It has a lot of phases. There is the clinical phase, there is the lab, there is the radiology phase, and there is immunological phase. So before we think about tapering or stopping, are we sure that our disease is controlled? You will say yes. So how? How you can be sure in my clinic that my patient is controlled? We'll use DAS28. So this is remission. We'll be happy that the patient is in remission, and we are using, most of us will be using DAS28. Is it precise? Actually, tender joint count can be influenced by OA or by fibromyalgia. Swelling joint count also the same thing. It can be missed in subclinical arthritis. ESR and CRP will be raised in a lot of other conditions. And DAS28, we all know it excludes the ankles and the NTPs. So it's not really a very good measure for disease activity. Or is it? We have other measures. We don't use this, but we have a lot of other measures. We have the Boolean, which is said to be good because there is patient prospective there. There is CDI. There is physician and patient used here. Also SDI using the CRP. But all are shown to be subjective, and they are not accurate. They don't reflect the actual disease activity. There is even DAS44. It's not used. There is even a concept of deep remission. The deep remission, it is said that there is no arthritis in this patient. And here you have to aim to DAS to be less than 1.98. Nobody uses that in the clinic. There is immunological status, and this is a new dimension, and remission. And again, we don't use that there is a new concept of multi-level remission. And this is a new concept in which use the shell model. The shell model have depth of remissions, and when you reach to the immunological remission in which the patient will have seroconversion, you can say that the patient is in deep remission. You should have the clinical remission and radiological remission by ultrasound, there is no arthritis, and then finally the immunological remission. We don't use that. So physical examination, it was shown that it will miss mild synovitis. And some patients are in remission, and they are found to have synovitis by ultrasound. And this may progress to joint destruction. So question number 4. Does the patient have subclinical disease activity using our composite measure that we use in the clinic? And it was shown in a lot of studies that patients in remission, they do have subclinical synovitis in at least one joint. So are we sure before we say that the patient is in remission that he does have or does not have subclinical activity? I don't think we are. So what's after remission? We have patients on biologics and they go into relapse. And we have what Dr. Hanan was saying yesterday, primary failure and secondary failure. We have that without thinking about tapering. So did we consider that? And finally, I will just go over the research. What does it tell us? I will just go over some studies, and most of the studies that I found, they are not well done. But anyway, the best one I found is the Petro study. It's a recent study done in Germany in which they have 303 patients. The taper was in 100 patients, around 100 patients, and 58% of them, they maintained remission. So in this study, maintenance of remission occurred in around 50% of patients. So would you consider tapering or stopping? This study by Prof. Yasser Al-Midani, I was part in this study in which we did divide 157 patients with rheumatoid arthritis who had low DAS28 for more than 6 months. We had the patients in groups. The one in blue tapered the biologic by 50%. And the last one, we did not change anything. So the primary endpoint was sustained remission at 1 year, and relapse was around 41.9 in the group that had taper, and the group that we didn't touch, we didn't change any medication, the relapse was around 6%. Another study, again, increased risk of flare when there was tapering, and the odds ratio will favor continuation. All studies, either small number or short duration, considering that rheumatoid is a lifelong chronic disease. And all the studies used DAS28, which I spoke about at the beginning of my talk. And thank you.